This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2020, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Optimizing Mechanical Ventilation, Human Thought, or Computer Algorithm. Dr. Ira Chaifetz is a pediatric intensivist and longtime member of the AARC, including the AARC's Board of Medical Advisors. Dr. Chaifetz discloses relationships with Philips and UpToDate. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability.
Hello, I'm Dr. Ira Chaifetz, and I'm here today to answer a question, or at least to help address a question of should we be using human thought or computer algorithm when managing pediatric mechanical ventilation. As I get started, I want you to think about your own views. Do you think that the mechanical ventilators are more optimally managed by yourself, by people, by staff using human thought? Or would patients be better managed, more effectively cared for if the ventilators were managing the patients through programmed computer algorithms? I'll go through data that argues both sides of this question. And at the end, we'll come back to your question. I will tell you in advance that I'm not going to be able to give you an absolute answer. This presentation is much more meant to be thought-provoking and to provide some basis for both sides of this debate. Let's start out with ventilator management done by people and the variability that occurs when clinicians manage ventilators. So we need to acknowledge that despite similar disease processes, in many cases, ventilator management varies between ICUs and often even within an ICU among various providers. Ventilator management strategies often vary based on the knowledge, anecdotal experience, and bias of the various clinicians involved. Let's look at some data that supports that statement. In this publication by Dr. Kamani in Intensive Care Medicine, what we see on the vertical axis is PEEP, and the horizontal axis is FiO2. The green horizontal bars represent the accepted standard at the time using the ARDS network data to manage PEEP-FiO2 relationships. But when you look at the data shown on the slide, it varies greatly from the green bars. Essentially, the data shown here, which is data representing individual clinician practice, is essentially a scattergram. The only real pattern that one sees on this slide in these data is that on the high end of FiO2, the PEEP values actually used by clinicians are greatly lower than the PEEP values that would be prescribed by the algorithm. So we see a great deal of clinical variability. This slide represents a heterogeneous group of all pediatric ICU patients. If we now take a subset of half these patients, half of the 6,000, and go down to about 3,100 patients, these patients all had acute lung injury. The data are set up the same way, with the green bars again representing the algorithm or the accepted approach, and the data shown again largely being a scattergram. And even on these patients with acute lung injury, the PEEP values at the higher FiO2 levels remain lower than what would be recommended by established data and guidelines. So we see tremendous practice variability. If we move more recently to this publication by Kit Knuth in Pediatric Critical Care Medicine in 2017, these data are very similar. The solid, darker blue horizontal bars, again, representing an established, accepted guidelines for PEEP FiO2 management. And the data on the slide, again, showing tremendous variability by institutional and clinician preference. This slide, I should mention, represents only patients with acute lung injury. If we now take the data from Kit Knuth, same publication, and we look here in the blue bars of peak inspiratory pressure, the red bars pH, and the green bars tidal volume, we again see tremendous variability through the first 7 days of acute lung injury. The greater variability seen on day 1 than day 7, but again, a lot of differences between providers and institutions. The other point that I neglected to mention that it's important to stress is that in this case, these 8 sites are the Collaborative Pediatric Critical Care Research Network sites. They're 8 sites which are quaternary care PICUs that are well-versed in the available literature and the available data. So if we're seeing this degree of variability in centers trained to follow the accepted medical literature, the accepted standards, we know that if we move this across PICUs across the country and across the globe, the variability one would presume to be even greater. So ventilator management variability, we talked about the variation between clinicians and units. We talked about the differences in vent management based on biases of clinicians. So what about the other side of this? What about computer-based decision support algorithms? Are they really the answer? Well, the goal of such algorithms would be to standardize care, to direct care based on accepted standards. And ideally, such algorithms would be designed to reflect the most current literature available and would be iterative over time. Cars and planes. Now, why am I going to cars and planes? Well, let's go through this and think about it a little bit more, because many times you hear the analogy of clinical care and safety in clinical care related to the safety and management in aviation. Let's think about this. So planes. Planes can fly around the globe on autopilot. Of course, there's a pilot in the cockpit, but the planes essentially can fly themselves, and they do so every day over the course of the year in millions and millions of miles. Cars, self-driving cars have become reality. So why can't we have the simple concept, or quote simple, of self-titrating, self-managing mechanical ventilators? Well, if you think about it, there's an important point to stress, and that for planes, every 777 is essentially the same. The mechanics of flying a 777 is the same regardless of which airline you're flying with. Cars, the concepts involved in driving a car are essentially irrelevant of the model or make of the car. Sure, different controls are in different places, but the concepts of driving are the concepts of driving. But the human body is different. Everyone is different. People, of course, come in different sizes. Disease processes differ. Specifically, pathophysiology varies between people and often within the same patient over time. And these patients have varying responses to interventions. There's intrinsic differences between patients, specifically their genetics. There's environmental differences, whether a patient smokes or doesn't smoke, or more contemporary issue, vapes or doesn't vape. Also, access to healthcare can vary from patient to patient and region to region. So we have limited definitive data in pediatric mechanical ventilation. We have limited data to clearly define and describe algorithms that clinicians can accept and will accept. So let's go through now computer-based decision support. Let's take that side of the argument for the next period of time. So such tools, such computer-based decision tools, should, and in fact often do, ensure replicable, evidence-based clinician decisions for equivalent patient states, assuming that patient states are equivalent, and I've already told you that often they are not. A goal of computer-based decision support is to improve protocol compliance and to generate explicit recommendations, clear, concise recommendations. If done correctly, if done well, they can be carried out with little variability between clinicians while potentially being responsive to each unique clinical situation. And that word potentially is really a key point here of whether or not computer-based decision support can and will be effective. Robustification is a concept rarely discussed in clinical practice, but is often discussed in general industry, especially automotive industry. So we know across the spectrum of industries, corporate executives have long accepted that consistency in design and manufacturing approach leads to the best possible product and outcome. Robustification specifically is the optimization strategy whereby a system is made less sensitive to the effects of random variability in the noise inherently present in most input variables. We're looking for a consistent, reproducible state. Although known to be an essential component of the Kadushi method, essentially the Toyota approach, of system design, robustification is rarely discussed in clinical medicine. And this is really a concept that would underlie true computer-based algorithm support of mechanical ventilation. We need to accept that human beings have a limited ability to incorporate information in decision-making. There's a limit to how many inputs the human mind can accept and process. This mismatch between this limitation and the availability of the extensive data contributes to varying performance and potentially errors in clinical decision-making. Variation in clinical practice is due in part to clinicians' poor compliance with guidelines and recommended therapies. Clinicians often will say, well, this situation, this algorithm, this recommendation doesn't apply to my patient today because of X, Y, or Z. Is that a true statement or not is still subject to debate. Decision support tools are a response to the data revolution and poor compliance with published guidelines. So let's go and look at some of the data. I'll start out with one of the earlier studies in pediatric mechanical ventilation looking at computer-based decision support. So this publication by Philippe Gervais in Peds Critical Care Medicine just over a decade ago had the goal of eliminating excessive noise and standardizing ventilation management. It used a closed-loop computer-based protocol using pressure support ventilation as the primary weaning mode. There's a lot of data on this slide, a lot of information on this slide, but the only real point I want to make here is look at the total number of patients enrolled. And that's one of the problems with much of the data that I'm going to share with you and the publications I'm going to share with you. They're all small. They're all underpowered to make definitive statements. So in this case, there were 14 patients randomized to closed-loop protocol and 20 patients randomized to a clinician decision approach. In terms of this initial pilot study, no adverse effects were seen with a computer-based approach. It appeared safe, but again, we need to acknowledge that it is an underpowered study and an underpowered statement. There were no differences seen in length of ventilation between the intervention and control groups, but again, underpowered. Besides the small sample size, the other limitations is such an approach only studied a single mode of ventilation, and the patients were already deemed to be ready to wean by the clinicians. One thing we need to consider when we think through computer decision support is the inputs. Are the inputs reliable? We know the algorithm is programmed, it is what it is. The outputs are what you determine the decision support, the computer algorithm to be, but what about the inputs? On this slide where we're looking at respiratory rate, EtCO2, tidal volume, see the variation over time, especially that spike early in the EtCO2 tracing and the significant variability in respiratory rate. Are those changes real? Do those changes represent physiologic changes? Or are some of those numbers errors? Are they motion artifact or other problems with the data input? Because we need to accept the point that the data, or the fact that the data input has to be reliable, accurate, to be able to get the outcome that we want, an ideal recommendation. In a follow-up study in 2013, the same study group looked at a similar approach using a single proprietary ventilatory algorithm to again try to assess computer-based management versus human thought. It shows how difficult these studies are. There were nearly 2,200 patients admitted during the time frame. And as you can see on the slide, the various inclusion and exclusion criteria. And once you got through the inclusion and exclusion criteria, there were only 30 patients remaining to be randomized, 15 patients per group. An extremely small sample size, especially considering the nearly 2,200 patients who were admitted during this time period. This study is again a proprietary computer-based algorithm, so it was limited to one ventilator and one mode, 30 children. In this case, they did see a decreased length of ventilation with the algorithmic approach. However, once again, the study was underpowered, as it was underpowered to show that there was no increase in adverse effects. With this, we again see a second study that shows feasibility. It shows that these algorithms work. They show that such an approach is possible, but these data are not significant enough or not robust enough to be able to make statements in terms of outcome and safety. There are similar adult data. This study here in the blue journal shows essentially the same finding with the same limitations of feasibility, but no definitive statements on efficacy or safety. In terms of PARDS management, and PARDS, for those who aren't used to that abbreviation, is pediatric ARDS. Can we even standardize management? So I've discussed the advantages potentially of a computerized approach. I've discussed the reality of human thought and human management of ventilators and the variability that we see. But if we are going to go down the path of computer support, computer-directed mechanical ventilation, will clinicians accept these guidelines? Will they accept a standardized approach to ventilator management? In this publication from Peds Critical Care Medicine in 2017, the Collaborative Pediatric Critical Care Research Network attempted to answer this question. They attempted to see if it was possible to standardize the management of ventilator management for PARDS. They studied 122, or surveyed, I should say, not studied, 122 pediatric intensivists and critical care fellows, again, across the 8 PICUs in this network. They used 50 clinical pediatric ARDS scenarios, and with that, they found that there was an 80% overall acceptance rate with the general suggested management approaches, which is quite good. An 80% acceptance rate, 20% rejection rate, for an early protocol, an early approach, is about what one would expect. So we see that, so maybe this is realistic. However, when you get into the granular details of what was accepted and not accepted, we see that there was little consensus with regard to the size or scale of the ventilator setting changes. So concepts were accepted, but details often were not. It is important to note that the acceptance rate varied by ventilator mode and the specific variable adjusted, and I'll explain that in the data slides in a moment. A lot of data on this slide. In terms of this slide, if you look at the demographics of those who were surveyed, you see really no main difference. One of the key, or no differences at all, I should say. One of the key points I want to highlight on the right side in the middle, and we look at the acceptance rate for attendings and fellows, they're actually the same. Attending physicians and fellows in training have the same acceptance rate of the suggestions from the computerized algorithm. Similarly, in the next box down, the next shaded box under that, what you see is years of experience, and again, no difference. Those with more experience accepted the algorithm approach, their acceptance rate was very similar to clinicians with less experience. Okay, let's move on to some more data here. Let's look on the top half of this slide about ventilator modes. And what we'll see is that the acceptance rate for oscillatory ventilation as well as pressure-regulated volume control was slightly higher than pressure control. I'm not sure how I can easily explain this difference, and I'm also not sure it's clinically relevant. But the real point of showing the slide is the lower half of the slide, which shows the ventilatory parameters. And when you look at the ventilatory parameters, the one that you see has the lowest acceptance rate is PEEP. And we'll come back to this point in subsequent data slides to show that the hardest ventilatory component parameter to gain acceptance in terms of a management approach is going to be PEEP. In terms of the magnitude of changes, if we look at FiO2 and the positive inspiratory pressure, we see that the acceptance rates for small changes and large changes are pretty similar. But again, PEEP is the difference. There was a higher acceptance rate at 72% for small changes, while only just over half of those surveyed were willing to accept large PEEP changes. So what happens when there are no data? No data at all. And we know there are no data to establish the oxidation index threshold to convert from conventional ventilation to oscillatory ventilation. And in these 8 centers, which again are centers that are quaternary care units, well versed in using various ventilatory approaches, including oscillation, we see great variability in the OI thresholds used. So when we do program ventilators, we do go to computer algorithm support, we need to base that on data. We need to base it on accepted approaches. And for certain entities, it's just not possible based on currently available knowledge. Perceptions regarding computer protocols. What do these faculty and fellows, what did they think? Well, most of the faculty and fellows felt that using computer-based algorithm was reasonable and was a good idea. Very few thought it was a bad idea. In terms of acceptability, as I put the rest of the data on the slide, I'm not going to read through all this slide because you can read through it quicker than I can. But as you scan the data, you realize that the general approach here is that clinicians feel that such a computerized algorithmic approach is reasonable, it's feasible, it's doable within their system, within their culture, and there really aren't a lot of barriers to such an approach. The key here isn't so much the concept again, it's going to be the details of how the algorithms are programmed, and how one accepts or declines the details of the recommendation more than the concepts. So the study concluded that it is possible. This is doable. Again, it's feasible to have such an approach. This was an excellent early step towards robustification of ventilation management for pediatric ARDS. We need to accept that there are limitations of this study, and the biggest limitations are that the tool used was never validated, and the survey was both designed and studied using the same 8 sites. And it's unclear if other centers, and you extrapolate this across the PICUs, across the US and beyond, would we in fact see different results? Just don't know the answer to that. A significant strength of this study is that the survey was based on the best available published management and recommendations and data at the time the study survey was performed. This is an example in this publication by Dr. Knuth of such an algorithm, a computer-based algorithm, where you have the various inputs. In the ideal state, these inputs would come directly from monitors and ventilators. They would not need and shouldn't need, and really it's unrealistic to expect any of this to be hand-entered. The data are fed into the algorithm, and then what will then be produced to the clinician, and this is a prototype example, would be recommendations that the clinician would either accept or decline. Now, behind such an interface are the algorithms. In this case here, we see an example from a prior study of recommendations based on PIP, pH, all the details here. The key of showing this slide is the color coding. And the reason I show the color coding is because when such an approach is used to manage ventilators, the investigators, the those designing the algorithm, those interpreting the algorithm over time, need to know for each cell, for each decision or each decision question and answer, what the acceptance rate was. So in this case, red is poor acceptance, green is good acceptance, and yellow and orange somewhere in between. Those cells that were consistently red over time need to be re-looked at in the sense of why are clinicians not following that recommendation? Is it that the algorithm is wrong or not optimal? Or is it that the algorithm actually follows the accepted data and the clinicians either don't believe the data, don't accept the data, or don't understand that specific recommendation? So really, those red boxes here require a deeper dive into the reasoning for such a finding. Okay, let's move on now. Let's move on and look at bigger picture. The Institute of Medicine, as published just recently in the New England Journal, supported computer decision support tools, including computer-based protocols, as a method to reduce medical errors. In this situation, it really, to be fair, the statement wasn't really designed or made in relationship to the management of mechanical ventilators for ARDS. It's really specific to glycemic control, but one could take this concept and, of course, extrapolate it to ventilators. What about other recommendations? So this is the PALIC, the Pediatric Acute Lung Injury Consensus Conference, as published in 2015 in Peds Critical Care. The PALIC international experts recommended that we should be using explicit protocols and definitions to guide research in mechanical ventilation and pediatric ARDS. This recommendation has been there for nearly 5 years. And with this recommendation, though, we still see very limited data, very limited studies along this concept. Where the future is going is still unclear, and we'll come back to that question at the very end. While the PALIC experts and a consensus group of experts have stated that the future really should be computer-based algorithms, it remains unclear whether intensivists generally share that optimism. Should computer-based programs really be the future of ventilatory management? I think the answer is going to vary tremendously based on who you ask. Let's think about this in a little more detail and think about some of the skepticism about such an approach. We've known since 2000, with the ARDS Network landmark tidal volume publication, that a 6 ml per kilogram tidal volume for adult ARDS improves outcome. However, there have since been multiple publications that have shown that the average tidal volume for invasively ventilated adult ARDS patients consistently exceeds 6 ml per kilo. Need to also acknowledge that for pediatric ARDS, we do not know the optimal tidal volume. We can either accept the adult-based recommendation or make an argument that children are in fact different. But if clinicians are not willing to consistently follow this simple published finding, what makes one believe that clinicians will actually follow consistently complex computer-based ARDS management algorithms? Again, a big debate and the focus of the underlying question of this presentation, human thought or computer algorithm. Well, let's now look about pediatrics. This is now tidal volume distribution in pediatric ARDS. We see a tremendous variability. Now, I do acknowledge that this publication is from 2010, but it was still 10 years after the ARDS Network publication, as I previously mentioned. We also know that clinicians are biased by the degree of lung injury a patient has. In this slide, what we see on the vertical axis is tidal volume. The horizontal axis is lung injury severity scoring. And we see higher tidal volumes used for those patients on the left with less severe injury than those patients on the right with more severe injury. Stated differently, clinicians have a bias or seem to have a bias that those patients with more severe ARDS, at least in this pediatric study, need lower tidal volumes. Or stated in reverse, those patients with less lung injury can tolerate higher tidal volumes. True or not, we don't know, but it is a difference that is seen in this study and multiple other studies as well. What about something as simple as FiO2 titration? What you see here on the vertical axis is number of observations. The horizontal axis is increases in FiO2. How much was an FiO2 increased between two sequential blood gases? Although there is a clustering here at about 5 to 10% changes, which is generally clinically accepted approaches, we see tremendous variability. Now, is this clinician variability or is this patient variability is unknown in this slide. But it does raise the question of how one would program a ventilator to make changes like this such that clinicians will accept them, and taking into account the degree of lung injury, the degree of change in lung injury a patient may be experiencing between 2 points in time based simply on blood gases. This slide is essentially the reverse. It's actually decreases in FiO2, a little more variability here between blood gases, but the same points I made, I want to stress that this may be challenging to reliably both program and for clinicians to accept the algorithms. A lot of data on the slide. I'm not going to go through it in a lot of detail, but I really want you to skim the slide and look through the time point differences. And if you look for each one of these parameters, look at the range of time, the time that clinicians are willing to wait or not wait between making a change, sometimes from just a couple of hours to often more than a shift. Great variabilities. So I asked the question, can we program an algorithm such that clinicians will accept that changes should be made every 10 minutes, 15 minutes, 2 hours, whatever that interval is, can we take this variability and narrow it to something that clinicians will reliably and consistently accept? And I don't know the answer to that. Clinician protocol disagreement. Okay? How often does a clinician agree with a protocol or not? This slide is divided into 3 columns. On the left, high PO2, well oxygenated, and all the way on the right, low PO2, obviously, poor oxygenation. We see 2 different categories. One is FiO2 changes, and below that, PEEP changes. And when you look at this, look at the low acceptance rate in this study for making changes in terms of a protocol recommendation. In fact, almost all of these data points, except for one, show that the clinician only agreed with the protocol less than 50% of the time. The differences here are quite striking. So one additional point that I want to make on this slide is the bottom half, again coming back to the concept of PEEP that I mentioned earlier. If we look at how often clinicians are willing to accept PEEP changes by protocol, on the high PO2 column, we see the highest number here of almost 59% acceptance. So if a patient is well oxygenated, clinicians are willing to accept a recommendation of how to change PEEP. But look all the way on the right side, the low PO2 column. Clinicians were only willing to accept the protocol-directed PEEP 24% of the time when the patient was poorly oxygenated. That's the problem right here, is that's the situation where one would want or one would need clinicians to accept an accepted standard on the patients who are more ill, instead of making the presumed statement that my patient doesn't fit the algorithm or the protocol. Okay, let's move on to another consensus conference. These are the recommendations for mechanical ventilation of critically ill children from the Pediatric Mechanical Ventilation Consensus Conference. This is essentially the European version of PLEEC. And what we're going to see on this next slide is really a definitive statement. And this follows up the PLEEC recommendation that we should be moving down a line of computer-based algorithm. But now, a few years later, let's read that second sentence. There are no data supporting superiority of any approach, such as protocolized weaning or closed-loop protocols. So although our earlier recommendation is we should be going down this approach, a few years down the line, we look back and say, we still have no data. So we can't make that recommendation because we simply do not know. So as we reach this point in the presentation, I want to now start bringing some of these concepts together. Let's go back to human thought and experience. Let's go back to the automobile industry. Okay, so in the automobile industry, again, every car of a certain model is essentially the same and static. But every patient is, of course, intrinsically different. And while that car stays the same over time, the patient changes, not only day to day, but sometimes minute to minute, hour to hour. Can an algorithm really keep up with those changes? Can computer-based ventilatory algorithms be designed to optimally manage a heterogeneous population of critically ill patients? Can the same algorithm manage a young infant with congenital heart disease and pulmonary edema, a 1-year-old with severe RSV bronchiolitis, and a young teenager, a 12-year-old, with severe influenza ARDS? It's really unclear. Can algorithms be designed to be specific to disease processes and patient age? Potentially, but we're still not sure how clinically applicable that is, and we're also at this point do not have data, definitive published data, to support various approaches, at least in pediatric ARDS. Hopefully over time, data will be coming, we'll be able to make more definitive statements, but right now we still have more questions than answers. And the bottom line is to argue the human thought approach and experience of the experienced clinician is that one can never underestimate the importance of the human brain and the human thought. So again, let's come back to the same slide. Can one program all the various situations, all the various combinations of patient variables, blood gas variables, monitored parameters, put it into an algorithm, put it into a grid, get output data that one could then go in an iterative process, fine-tune the protocol, improve the protocol over time, such that we truly get the optimal approach to ventilator management? Again, more questions than answers. Here's another look at various approaches to this, and this is really meant just to show an example of how one would look at various cells, various parameters, various recommendations, and clinician acceptance or rejection of those parameters. The reason I show this is to stress that point that if one does go down the route of algorithms, computer-based approach, it must be an iterative process over time, because it would be impossible to get the perfect algorithm, the perfect scenario on version number 1. So as I start concluding my comments here, planes, again, every 777 that flies around the globe is essentially the same. Pilots are trained on one 777, can fly another 777 with minimal, if any, additional education and training. Cars, driving a car is driving a car. But again, the human body is different, very different from patient to patient, and again, within the same patient over time. We need to have algorithms that in pediatric ARDS, pediatric, more generally mechanical ventilation, that can range from essentially newborns up to young adults. We need to have algorithms that will address, as I've mentioned, various disease processes and physiologies that may have various responses to various interventions. We need to always consider genetic differences that might make one person respond to one therapy very different than the next patient in the next bed space. We need to again consider environmental differences that may make one patient different than another. And we need to accept the fact that we do in fact have limited definitive data in pediatric mechanical ventilation. There are other limitations, especially when you get into closed-loop systems. I want to emphasize a point I made early on, and that's the reliability of the inputs. If an algorithm is going to be based on end-tidal CO2, we need to be sure that that end-tidal CO2 signal is accurate, reliable. We need to be sure the SpO2 is real and not artifact. We need to be sure that respiratory rate change is related to the patient's lung condition and not because of a young infant being scared or excited or crying. And also, I will not go through the details in this talk, it's beyond the scope of what I'm covering, but we have to remember and accept that there are regulatory hurdles to such approaches as well, largely due to concerns over the input variables. So as I conclude my comments, what does the future hold? There are certain points that we know are true. We know that technology will continue to advance. Not many can argue that point. We know that the data explosion will continue. In the past, we had data every minute. Truthfully, today, we have data every breath, data every heartbeat. Every piece of possible data can be collected. It's what we do with those data that are important. Hopefully, we'll have more definitive pediatric management data on the horizon. How do we optimally manage the mechanical ventilator for the pediatric patient with acute respiratory distress syndrome? How do we optimally manage the ventilator for the patient with normal lungs as well? It really is the continuum of care. I believe that decision support computer algorithms is probably, if we go down that route and it really progresses, it's going to be much more of an evolution than a revolution. We've seen the slow progress to date. I suspect, and this is just now me speculating, it will continue at a gradual pace, although, of course, we don't know what technology is going to lead to, and we don't know what the acceptance of that technology will be. So truthfully, only time will tell if ventilator management will continue to require individualized human thought, or whether computer-driven algorithms will eventually be demonstrated to improve outcomes. And we have to remember one important rule, and that's the rule of 80-20. As we saw in that earlier study from the Collaborative Pediatric Critical Care Network, where the surveyed faculty and fellows had an 80% acceptance rate of general management guidelines. 80% is standard. That is what one usually strives to get, at least early in a process, early in a protocol development, early in a project initiative development. Hopefully, as care improves, as management improves, as data becomes more plentiful, we can get up towards 90-10. But the question remains, can we ever get to 100-0? Can we ever get to an approach that truly works for 100% of patients? This is the difficult point here, because the difficult point is until we get to 100-0, and you're at 80-20 or 90-10, how do you predict that patient or those patients that truly do not follow the protocol? That's the challenge, because if we knew that answer, if we knew the patient that did not meet the protocol, then we could easily get acceptance for such an approach of computerized management for the other 80 or 90%. How do you determine the patient that follows the rules versus the patient who does not follow the rules? And that's the underlying issue that we really need to think about and consider. So in the end, as I conclude, really, what's your opinion? Hopefully I gave you data to consider. Hopefully I asked enough questions that I have you pondering this topic. I wish I can conclude with a definitive answer for you, but at this point we still have more questions than answers. I hope you will continue to think about this approach, think about whether ventilators should really be managed solely by human clinicians, by the human brain, or by a computer algorithm that is a closed loop process where essentially the ventilator manages itself. Now in the end, if you really think about it, it probably will never be one or the other. We're probably going to get into some combination of both, at least for the foreseeable future. But unfortunately, more questions than answers. And with that, I thank you for your attention, and I appreciate being here to be able to share my thoughts with you today.